Hello, I'm Pam Greene, and I'm here today to talk to you about IBHC, Team Processes and Outcomes. IBHC is really the Integrated Behavioral Health Care Team Processes and Outcomes, and it's part of the Tex-CHIP grant. Let's start with clarification of terms. When I'm talking about integrated behavioral health care, we're really talking about this emerging approach that's aimed specifically at improving healthcare delivery. What we're wanting to do is include behavioral health, which is mental health and substance use care, into primary care. And again, the teams do not have to be located together, but they meet the definition of integrated care when they're working together in tandem to meet the needs of an individual patient. And we want the patient to feel that they really are at the center of care, because after all, that is what our work is about, is taking care of that individual, and it may extend to their family or it may extend to significant others. So we're looking at establishing partnerships or an alliance among practitioners, patients, families, and others whenever it's appropriate. And when I'm talking about systematic, I'm talking about having a routine or part of care that incorporates or integrates behavioral health care, not as an add-on or an afterthought. So the aim is to improve healthcare delivery. The idea of transforming primary care to truly integrated behavioral health with primary care, I refer to as whole care. And it's not change just to have change. It meets the growing need that's been going unmet. We really do want to meet at the primary care level all of the needs of the patient. And to do this, we also have to have measures of improved or effective health care that links to outcomes so that we know if we're doing our jobs. So how do you know if you are effective integrator of behavioral health care? Well, the simple answer is outcomes. But a couple of questions I want you to consider is, do you have the capacity and the systems in place to provide population-based care for patients with one or more chronic physical or behavioral health condition? I doubt that any of you would do an absolute no. Most organizations are at least doing a little bit, if not more. And if your answer is yes, then you are really enhancing and achieving the three aspects of the triple aim from the Institute of Healthcare Improvements, also known as IHI, where you're looking at improved healthcare outcomes, better patient experiences, and value of care. And that really is referring to economics. And another question to consider is, do you have behavioral health embedded in your continuous quality improvement, your CQI? And is behavioral health included for all disciplines? I know sometimes there may be a CQI question that's looking at, does the nursing staff consistently do the behavioral health assessment for every person coming in? That's nice, but it doesn't extend to all disciplines. But if you can answer yes to that second question, then you're terrific. You are already on the cutting edge. And there is value in continuing with this particular module because it reinforces the good work you're already doing. If the answer isn't a resounding yes, then it's time to dig into the available tools and start small. Take baby steps to expand your focus beyond physical conditions. And really, AHRQ comes to the rescue. That's the Agency for Healthcare Research and Quality. Many of you are probably familiar with this organization and may have already accessed some of their resources. One that's important I have listed here, and you have that URL that you can find. In this, they look at ways of integrating behavioral health into primary care. It's a way to include the knowledge base, the research and insights. It provides definitions, ways to measure, strategies, and lessons learned. After all, if somebody else already had a struggle and you can avoid it by learning from theirs, by all means, please do. And one of the things I find helpful with this particular site is it's very logical and easy to use. And it extends to this particular site, and they call it the playbook. And it's exactly what you think. It goes step by step of what you can do. There's a self-assessment checklist. There's an implementation plan. But that implementation plan is developed so that you can individualize it for your own organization. Gives you ideas about how to establish your operational systems, and what about financial support, because that's always a piece of it. How to develop that shared plan of care, and dealing with setbacks. Setbacks will happen whenever you're trying to make changes at this level. And it also has additional resources, but I wanted to really let you know about this. As a former hospital executive, this thing is like golden. And then there's the Atlas of Integrated Behavioral Health Care, and that really focuses on quality measures. And so when you're thinking about looking at ways to integrate behavioral health care, you want to look at what is the framework that you already have, and it gives you some frameworks that you can use, and wanting to do that with some existing measures that others have used, and organizing that in alignment with your own goals. So it's not asking you to change a whole lot. It really does try to integrate this idea of quality measures within the system that you already have. So we think also about the team processes with IBHC, and you're thinking, are we shifting gears? Not entirely. So with the triple aim, you're enhancing the three aspects of care from IHI: improved healthcare outcomes, better patient experiences, and value of care. Well, that takes a lot from providers. It takes a lot of documentation, and it does impact the way that you work. And that's how kind of the quadruple aim, which is proposed, came about, because what happened is when you are working on all of those other aspects, it takes a toll. And so the fourth aim is looking at improve the work life of healthcare providers. That includes clinicians and other staff. I'm not talking about work-life balance, although that really does come into play. It's about your work life, the demands, the feeling of being overwhelmed, stressed, and burned out. We want to do things to prevent all of that. So another way of thinking about this is the improved experience of providing care, because it is demanding to be so involved with individuals every day. So how do you know if the experiences that your team members are having are feeling rewarding and they're enjoying their work, or they're ready to walk out the door because their brains are fried? Well, one of the things you want to do is, again, look at outcomes, and you want to look at your team members, and you're going to apply that. And if you find you're already doing it and doing it well, terrific. Then you want to look at sustaining practices. But remember, this gets tricky because there is no one team specifically. The team varies pending the needs of each individual patient and based on the changes within the patient's needs. So are we happy at our work, basically? And if we are, we provide better care. When we're not happy, we're distracted, and patient care suffers. So it is important, once again, to think about this overall. So how do we do this for our teams? How do we make sure that the teams are in the best possible shape? Well, we talked earlier on one of the modules about the team formation: forming, storming, norming, and performing. And it's especially important to remember in that forming stage to have very clear roles and responsibilities developed. We want to know that there are clear communication processes in place, and how to keep everyone in the loop, and how to maintain HIPAA. All of those things are important, as well as timeliness. So that's one of the strategies, and to make it as seamless and easy as possible. And that can happen if your IT staff, for instance, is involved in developing the electronic health record in ways that support the functioning of the team, rather than the team having to bend to the computer system or the electronic health system. Use of shared governance is another important strategy that can be helpful. Nursing has used that for a long time, but it's certainly one that can be used universally. And that's a structure that gets put in place where everyone has input into how to shape and a share in the decision-making processes that are relevant for their work, so that you all are working together again for best outcomes, but you feel invested in that process. The last example I want to focus on is clinical supervision. This is a formal working alliance where the supervisee's clinical work is reviewed, usually by someone who's a bit more senior. And often in education programs, people have this. It's a little more rare today, found in clinical practice, but it's something important when a major change like this is being undertaken. The supervisee's work is reviewed reflectively, and the idea is for that person to get support, and it supports then their ability to provide good patient care. It helps them with treatment standards and best practices. It helps with safety as well as ethical practices. And to do clinical supervision, you need organizational support. I always think of billable hours. If you give a half an hour to the supervisor and supervisee to meet, that's a half an hour that you don't get to charge for. But in the long run, it may be your best investment ever. One of the things that can be more economical is to have a very senior clinician provide group supervision. And it can also be very rewarding to hear from others and have those shared conversations about challenging patients or experiences, as well as the success stories. And it's very different than manager type supervision when we're talking about coming to work on time, getting your documentation done, those kinds of things. Ideally, the person who is in supervision comes to value it and even looks forward to it, and will bring perhaps notes in a journal to use in that format. In one organization where I worked, quite literally every person, whether they were clinical or not, had supervision, because even the person who is the dishwasher receiving the patient's tray is taught to notice how they're eating, and are they eating, or maybe they only ate desserts. And how do you then get that information to the treatment team? It's not as sophisticated as the supervision that's provided for some of the behavioral health clinicians. Or think about the primary care person who is now trying to have an appreciation for how to alter their practice to be more inclusive of behavioral health. There's a real value in all of this, and so I highly endorse and encourage thinking about clinical supervision, and there are different models for it, so you may want to think about experimenting with a couple of different models in terms of who's included and how they're included. There are some available guidelines, and again, that URL is right here on the screen, and it's an investment that I think is valuable both for the supervisor and supervisees.
Hello everyone, and thank you so much for being here today. Today we're going to be discussing IBHC team processes and outcomes. So before we get started, I wanted to just take a moment and go around the room and have you guys introduce yourselves and speak a little bit about your discipline and where you're currently working.
Sure. I'm Dr. Kendra Saxvik. I'm a clinical pharmacy specialist. I specialize in mental health, and I'm currently working in specialty mental health care at the VA here in Corpus Christi.
And I'm Pam Greene, an assistant professor in the College of Nursing and Health Sciences here at Texas A&M Corpus Christi. I've been here just over 3 years, coming from the clinical setting where I worked in psych mental health for the last 39 years.
I'm Kristen Hines. I'm an LPC, and I currently work in primary care mental health integration at the VA outpatient clinic here in Corpus Christi.
Thank you all for being here. So I think when we're talking about team processes and outcomes within integrated behavioral health care, a good place to start would just sort of be what kind of opportunities can come from integrated behavioral health care, and as far as implementing that from a systemic perspective with the process and kind of what you can expect from it.
Well, some people who are tuning in at this point have probably listened to some of the other modules or perhaps not. But what we do cover is the fact that this method of providing health care very holistically is effective and efficient when it's done well.
Absolutely.
Yes, and when we think about outcomes, some of it, administrators like to see hard numbers a lot of times because that's easy to be able to present and see where changes are. And it can be a little bit different and difficult to do that with this type of model. This is still fairly cutting edge within medical community, so there's not as many studies out there that can say, all right, you can save this much money or you can have this much reduction in these outcomes because that information just isn't there yet. But what we have seen in some of those outcomes is it can reduce hospitalizations, which saves the system money. It can increase your employee satisfaction, which saves you money because people are likely to stay within the system. It reduces your turnover there. And so looking at a systemic level, those are some of the outcomes that administrators may want to pay attention to and look at once they start integrating this type of model.
And to do that, we have toolkits available, and that's outlined in the PowerPoints from the Agency for Healthcare Research and Quality, AHRQ. And I just really recommend, rather than trying to reinvent the wheel for that, for people to look at those resources. And I think they're pretty easy to implement when you think about how to assess, because you do have to have data. Everything we do should be based on evidence and be data driven to really know that we're doing best care that we can. And on something like this that's cutting edge, sometimes it's hard to know where to begin. And these toolkits really help guide people. They're very straightforward, they're very step by step, and I think that it's helpful to learn from what other people have done so that you're not trying to start from scratch when really and truly these toolkits are designed to look at one thing at a time. And they use familiar frameworks for that through like Plan, Do, Study, Act, that sort of thing, and can help you in terms of even determining what should my measures be based on where I'm at in this implementation process.
Absolutely. And so with that being said, so it sounds like really one of the benefits to something like this is there is sort of a manualized approach to the best way to incorporate something like this into any sort of facility. And so what kind of challenges do you foresee with something like that, or have you been through yourselves in implementing kind of team process and outcomes with reference to integrated behavioral health?
In my previous job, we received a grant from SAMHSA where I was the first integrated therapist in primary care. And so that was, it was all brand new. And so we built a lot from the guidance that was already out there. We used the 4-quadrant model and looked at what that clinic might look like, and we used the integrated scale to figure out where we might start and how we might move up through that. And so we really had to start from the bottom there, and it was really important to have a lot of administrative help with that and clinical supervision help with that too, to figure out how is this going to best serve this clinic, and what measures do we need to be looking at? Are we looking at like clinic utilization, or are we looking at improved patient care if the integrated therapist had been involved? And we really, it's a lot. It can be a little bit overwhelming, but ultimately it proved to be very beneficial for the primary care providers to be able to pass on some of those previous responsibilities of theirs to diagnose for mental health issues or assess for ADHD and give that to somebody who has more specialized experience with it. And ultimately, the clinic benefited quite a bit from it.
And when you mentioned that, it's like if you're starting at the beginning, you can look at what is out there so that you're also not having to create the mining of data as a second other work piece for someone. It can be incorporated into the workflow so that at the end of the day, it's easy to get the information that you're looking for your outcomes. Whether it's through the electronic health record or some other form, but just be thinking of that from the beginning as well.
Absolutely. And so I kind of want to take it back for just a moment. You had referenced supervision a little bit with reference to engagement. Would you be able to expand a little bit on what that looks like?
Yeah, so in that role that I was in, my clinical supervisor was very much involved. He was in the clinics, making sure that primary care providers knew who we were. He spoke with the chief medical officer to make sure that person knew what we did and how we could help. He really did a lot of advocating for this integration piece to show them, like, this is really good, we need this, we need to continue this, because the grant was for 2 years and they wanted to continue to have funding for it after the grant had run out. So really making sure that everybody knew that person was there and they could use them. I mean, without him, that role I don't think would have taken off the way that it did. And he did a lot of work too in figuring out how we're going to measure these things and how we're going to prove that this is incredibly helpful for this clinic.
I think another good role for the clinical supervisor is helping new practitioners kind of figure out what exactly their role can be and help foster not only this is the role that as it currently stands, but where can it go? Where can you as a new practitioner take this so that it's not only beneficial for the clinic, but also for their practice and their experiences?
Absolutely. And there was like stages he went in. So first it was just get in there and make relationships with these people. You're going to be working with them, make sure you get to know them. And the second phase was, okay, we're going to introduce a universal screening tool that the primary care providers are going to give annually to their patients that will check for depression, anxiety, substance use, suicidality. And then the next one was, okay, how do we build your caseload now? So making sure that you're slowly easing into it and not throwing everything at once, which again, I think where these guidelines can come in play, because just trying to jump in and reinvent something is going to be incredibly overwhelming.
And one of the pieces in the toolkit is important. It's the lessons learned from other people. So I think that's almost the place to start to prevent the beginning from making mistakes that others already made and learn from that to make it go smoothly. But I think it's very cool that you had a supervisor who was such a champion, because for any major change or shift like this, champions are important, but to have someone at a higher level within the organization makes a big difference.
Absolutely. And so in looking kind of at our geographic location being here in South Texas, what kind of things do you guys think are imperative as far as the foundation of integrating and sort of developing this team process?
For me, and this comes from a long history in psych mental health, I believe that the clinical supervision piece is important no matter what. I have had the experience of it being embedded in all levels, but what is the pushback is it's expensive to pay when you think about time, the person who's providing the supervision and the person receiving the supervision. So that's considered, in quotes, non-productive time. They're not billable hours. They're not hours that you're seeing patients. In the long run, though, it is such an investment in the development of people, and it goes a long way toward retention, and we know that. And when you're trying to have a big turnover, it's costly to recruit new people and to get them oriented, to get them up to speed. And so you have to look at this from the long-range perspective and not the short range. And over time, that supervision can shift or change and even go from individual or one-to-one supervision to more brief supervision, maybe less frequent, or even group supervision. So there are ways to economize and not lose the impact of it over time, but up front, it's an important investment.
And I completely agree. It's an important investment up front, but from an administrative standpoint, understanding that, because in our geographic area, it's hard to recruit. It's hard to recruit for a lot of positions. And so if we can come up with a model that has some of the supervision that engages people and then they want to stay, that reduces your need to find people and recruit in an already difficult location. And so when we look at it in the long range, it can be an extremely beneficial anywhere that you have shortages, which is definitely this geographical area, but also really any rural areas.
And one of the things that we've lost in the whole field of psych mental health is the art of clinical supervision. People know it from the standpoint of academic supervision of people who are in practice as they are gaining their advanced degrees. So one of the toolkits that we have available too is one for clinical supervision for people who are seasoned clinicians but maybe don't really understand how to provide ongoing supervision.
Right.
They know how to provide it to the person entering or during that student time or supervision to get licensure, but then what? And so that's an important thing too, is to understand how important it is really to carry it on through practice kind of forever in an ideal world. That's listed also in the PowerPoints, is the toolkit for how to even provide supervision. Coming from Menninger, quite literally everybody was receiving supervision, and we taught people how to provide supervision, and so there was nobody at any level who didn't get supervision, which was amazing. And so you never really want to leave that kind of environment, so it goes a long way for not only recruitment but retention.
And I think that toolkit that you mentioned would be a great thing for administrators to be able to look at, to identify people they already have within their organization that might be able to utilize that toolkit to start this kind of more on a less intense level.
Yes.
And start moving towards that clinical supervision on all levels. Because you got to start somewhere, especially if you don't have it.
And identifying people who really have an interest, because not everybody really cares to provide clinical supervision. Not everybody's good at it. It's a separate skill set that can be built. And it's just like teaching. Not everyone teaches that effectively. Not everybody's meant to be a clinician. So
Right.
identifying those people who can champion that particular part is real helpful.
Yes.
All right, thank you. And the last thing that I kind of wanted to talk a little bit about was I wanted to hear your perspectives on multicultural considerations or ethnic considerations, particular to our location here in South Texas, but also what kind of things in general can be recommended.
I know we were talking earlier and you were mentioning some things.
Some of the things to consider, particularly in South Texas, we do have a large Hispanic population, and so we need to make sure that we consider that and their cultural considerations whenever we start trying to build these and look at outcomes. And it's not just Hispanics, but there's a lot of cultures that have some what we would call alternative medications or alternative medicines, and being able to recognize the importance of that culturally. When we start building these team processes, making sure that we keep an open mind to some of those cultural considerations, and that actually helps the buy-in of the patients. Because if you have a provider that just completely disregards your culture and your preferences, you're not going to trust them. You're not going to do what they say. If they completely disregard what is important to you, and not integrating that into a holistic kind of treatment center. And so when we think about developing these teams, making sure that we have members of them that really can truly understand the local community. Here in South Texas, I think you'd mentioned earlier that we have a lot of providers that aren't from this area, and so they don't understand some of those cultural things, and that can prove that comprise a significant barrier in being able to recognize what processes need to be put in place and how do you measure some of those. If that makes sense.
Absolutely. And when looking at outcome measures, making sure you're looking at something that is culturally appropriate.
Right. What is an outcome measure that is actually realistically measured in this area, and is it relevant? What is relevant here in South Texas may not be relevant in Seattle, Washington.
And even the interaction between team members is impacted by the cultural differences within the team. And this is really simple, but it highlights sometimes we don't appreciate even the language differences of people that may have come here to practice from other countries. We were getting ready to do an event and we were looking at marketing materials and we were talking about Frisbees. One of our team members is not from the States. he did not know what a Frisbee was. You know, it's like, oh. So even simple things, sometimes we have to stop within our team and make sure that what we say is being understood in the way that we meant it when we have people from other areas of the country or even other countries or other backgrounds.
Absolutely. Thank you for that. And before we draw to a close, I guess I just kind of want to open up the floor and see if there's anything that anyone feels really relevant to mention before we close.
Just getting buy-in from your clinicians as to what outcomes they would find important as an administrator. And on the flip side, as a clinician, finding out what is important for your administration to focus on, to have a really collaborative way to move forward, and that'll increase the likelihood of success for everybody.
Well, thank you all for being here today.
Thank you.